We're going to talk about a topic that almost seems treacherous, right? Why would the AST president be talking about AI with sleep technologists? It seems like I'm the enemy when I talk about that, but I'm not. And I hope by the end of today, we have a different perspective on what artificial intelligence is in sleep, because I think that there's a lot of opportunity when we think about it. And by the end, I think I'll try to make my case, and hopefully you still love me by the end of this. As we learned, I am the Director of Clinical Affairs for Knox Medical. A lot of fun doing that. Being president of the AST is a very, very busy job. There's a lot going on there. If you don't know, just super quick, we reunited with the ASM August 1st. So that was quite the journey. And I've got some bumps, some bruises, some scrapes, some scars, but we made it happen. And we're better together. You know, that's I believe that with all my heart, that we've got a great future together. Also exciting is we will be back at the national meeting. So the AST will be in charge of the sleep tech track. We will have our annual meeting there. It will be like old times. So it's exciting. It's scary. The weight of the world, I feel like that mythology character with the big world on his shoulders some days. But you know what? We got a lot of fun things in front of us. And, I'm excited about that. So today we're going to talk a little about artificial intelligence. And I think that there's some really cool things about it, that we're going to distinguish between the benefits and limitations. It's not perfect. If anyone tells you it is, they're fooling you and themselves. So, and then the really fun part about this is when we get to talking about endotypes. For me, that's almost like crack cocaine. It is just the coolest stuff that we have in medicine. As we talk about genotypes, endotypes, and phenotypes, we begin to really talk about some fascinating things. But let's take a step back in time. This is a very old picture of Dr. Rex Chafin. I hate to say this, I do kind of miss paper. That was a fun time. I didn't realize it was fun until it was gone. But it was a cool period of time, to have the paper machines, and you would hear something happened, with the heart, or the patient moved, you could hear the pins change. So much so that I remember when we went to computers, my techs asking, can we have pin sounds? So I can know what happens with the patient when I'm not looking at the computer, because they knew, right? And so many of you had that experience too. But what's crazy is, as we look at the global situation with sleep apnea, the percentages haven't changed much. I started with Respironics in 2001, and I was the clinical trainer for North America. And I remember, I would go around talking about, hey, this is so important because 90% are undiagnosed and untreated. Do you know how much that number's changed in the 24 years since I started saying that? 5%. It's 85% now. So we put a dent in it. And as we heard from Robert, there's a lot of other tools that are in the pipeline to help with that. But the population isn't changing. The size of the problem is massive. The comorbidities associated with sleep apnea, we're learning more and more about that, right? We're learning of consequences. So this will tell you about a crazy moment in time for me. So this is probably 2002, 2003. I'm giving a talk in Tarpon Springs, Florida, right outside of St. Pete. And I'm doing a talk on this revolutionary idea, OSA and hypertension. Not so revolutionary anymore. I had doctors in the audience telling me I was full of it, that this wasn't true. I need to just stop where I was. That's how much things have changed. And when we think about this, and sleep testing is changing. We have our type 1, our type 2, our type 3, and type 4. Type 2 is a thing that's coming. That one is something that, as we begin to learn more about how that is, and type 2, if you don't know, a type 1 is a full sleep study and the sleep lab attended study. A type 2 is a full study unattended. The technology is getting there. Just like with AI, and I hope you hear this at the end, how do we own it? How do we own it in our market? Because if we wait around and just sit there and think about all these changes from the standpoint of, well, I'll just wait for the next shoe to drop, and I'll change careers then you're missing my point. Technology is an opportunity. Innovation is an opportunity. I went to a friend's house in Seattle that used to work for Respironics, and he had over 1,000 CDs on the wall. It's beautiful. How useful is that now? Right? Instead of 10,000 songs, of which he probably listened to 1,000, he now has them all on his phone, and it's just 1,000, not the 10,000. Things change. So in sleep technology, things are going to change. It's not a threat. It's an opportunity. For the people that see it as a threat, they're going to get left behind. For those of us who see it as an opportunity to change what we do, then it's a fantastic future. And so one thing that's going to disappear, we heard this, not disappear, but it's become less and less, is CPAP. I mean, my wife was trying to give me sleep advice the other day. I said, baby, CPAP built this house. I know a little bit about it. And but the truth is that it's going to eventually not be our first line, but right now it still is. CPAP is where we have to start because that's what the payers say, right? So as I talk about the things that are coming, and we hear the things from Robert earlier, the treatment pathway is still pretty solid, but I think it's going to change as we learn more. Because one of the problems is that adherence really hasn't gotten better. I mean, I remember when Respironics brought the Gold Seal mask out. I was like, oh my God, this is so cool. It's 7 sizes, and I got purple boxes, and I mean, it weighed like 10 pounds on your face, but you were really impressed because it was so cool. Well, now we've got amazing masks that just are so light on your face, and so many new things, and we've got all these pressure reliefs, and we've got tools, and adherence isn't actually any better. CPAP's stuff to live with. Matter of fact, when I first started wearing it, I was one of the trainers for North America, and I was not adherent. And I was going around the country teaching people how to set up CPAP, and I wasn't adherent on CPAP. That's a great commercial. But eventually I did. But the challenge is that, it is tough to become adherent with. And I think one of the statements I made on LinkedIn a while back is that, one of the things that's disappeared more and more from the sleep testing process is the tech. And we've seen adherence drop. Matter of fact, the number is that after a year, when the DME stops doing all the follow-up at that rigorous rate, it plummets. Matter of fact, after 4 years, 1 in 3 patients is still using their CPAP. And that's the truth. So we have treatment options. We heard about these earlier. But here's the thing. So if you ever have insomnia, there's a really great book to help with that. It's called Thinking Fast and Slow by Daniel Kahneman. It's fascinating. And it talks about the different ways we think. But one of the things he talks about is this idea of sunk cost fallacy. And we've all done it our whole lives. So an example is you invested in something with your kids. Maybe let's pick something really banal, but you got a piano lessons for your kid. They're terrible. They're tone deaf. So you're like, man, I'm going to keep working on this. We're going to keep practicing. They're still tone deaf. They can't distinguish notes. But we've invested so much in this, we're going to invest more because now we're married to this thing. We're going to win. That's sunk cost fallacy. So think about that in CPAP. Okay, sir, CPAP's going to work. I'm going to make it work. And I'm going to coach you, and we're going to learn, and we're going to try 1,000 different options instead of asking the question, was it the right therapy to begin with? Part of the challenge is we don't know that. And that's where endotyping becomes our friend. We'll see that in a few minutes. So artificial intelligence, it's a lot of things. It's a catch-all phrase. How many people think it's a fairly new thing, that it's only been around a little while? Okay, we'll come back to that in a minute. Well, they had a debate about this. A very good friend of ours, Massey Arrington, was debating the cons of it. Dr. Octavian over here was debating the pros of it. This was at Houston. this past year at Sleep. It was a great debate. They did a fantastic job, but as you can see, for both sides of this, there are pros and cons. And even the Academy has really dug into this, and we'll talk about this in a few minutes with the SWOT analysis they did. But here's the sobering statement. Machines could replace physicians or techs. I mean, think about it. If you've got an algorithm that's assessed a patient, assessed the sleep study, and given us a prescription, a diagnosis and a prescription, who still has to set up the patient? We do. Who still has to educate the patient? We do. Right. But technology is as much a risk. We fit into all of this. So back to the other question, in artificial intelligence. About 1950. Anybody ever see the movie The Space Odyssey, 2001 Space Odyssey? That was 1968. So of course you're like, well, that was a movie, that's sci-fi. Well, 10 years before that, we were already talking about artificial intelligence. It was already here. And so it's not a new thing. And so I hear people say, well, what about scoring? I'm not doing a commercial. Actually, this product doesn't really exist anymore, but I had Sandman in 1999. It had auto scoring. It wasn't good, but it was auto scoring. So the idea that this is a threat to us isn't real. It's just scary because we don't understand it. And I think that's what I hope we discover today. So there's a process of how AI happens. And that process, we would actually program a computer. This is pictured here as classic programming, where we have rules and we have data, it churns it up, works the machine, and we get answers. But when we start talking about AI, it's a bit different. Now we're feeding in a whole different, we're actually feeding in the study. So we're teaching the technology a K-complex, a spindle, stage 1, stage 3, different types of respiratory breathing disorders. All of it is being fed into it. And so what ends up happening is the machine learning with the data and the answers. Manual and the scoring rules, right? That's where it comes from. We have that feeds into the machine learning that creates the rule, and then the rule drives the classic programming. And that's the loop that we're dealing with. So that is the picture of it. To its easiest form. But let's look at what happens in a simple situation when we don't have clear rules. So how could puppies and cupcakes be similar? It's kind of crazy. So we have dark eyes, dark snout, 2 ears, light to dark brown fur, versus a cupcake with a round shape, paper liner, may have frosting on top, and have made blueberries or chocolate chips, right? If we don't have the right kind of rules or data we're feeding into it, we may end up with an error, and worse, and we'll see this in our SWOT analysis, wrong data, or bias, which is even worse. We can even see this with cats and croissants, right? That's what happens when we don't have a clear picture of what we're looking for. The machine can only do what it's been taught. It can't work magic. So it's like, remember back to when you were first to tech and they started garbage in, garbage out? You can't filter all the garbage away if you don't do a good job. It's not that different when we start talking about AI. It's still, if it learns garbage, it gives us garbage. So that also means that we really have to understand and ask questions when we're looking at, the technology that's doing some of this work for us. But we have rules we follow, and the Academy is involved in this process of establishing guidelines, establishing rules, and they've done a good job of that. They've got a great team that is in there, and I'll show you an article that you can read if you want to take a deeper dive. So what it's not sci-fi. We're not there. I mean, it's easy to dramatize all of this and make it exciting and want it to be magical, that it's going to give me these magical ideas, but it's not what they want us to think it is from a Hollywood perspective. I love this statement: if a human can do it, AI might be able to do it, or may be able to. So I think it's important to have that perspective. So when we look at these, you've got different types of AI. You have the static versus AI that learns continuously, autonomous AI, human in the loop, and extracting new information. The governments are catching up on it. Regulators are. All of this is, I mean, nothing's happening in this black box where we're not involved. And there are rules. Canada has rules. Health Canada, the FDA has rules. The European Union has rules. So everyone's dialing in on this as to how these things can be built and what can happen with them. And that's important. So if you're talking to someone who's selling some type of technology, it's important to ask them those kinds of questions to understand, what their limitations are. So when we think about the limitations, I love the questions in this for selecting the right. Is the task at hand easy or difficult? And we can see from other companies that have AI, it's been a journey. They've learned over time, they've gotten better, and even like our auto scoring that we've had on our PSG systems for some time has been learning this. It's been, it was already being programmed to recognize waveforms, to recognize respiratory events, leg kicks, all of it. So that's all available there, but we have to have the right data in to train the model, right? So can the output be predicted from the input data? It needs to be. There should be, if X, then Y. That's not going to be a question. It has to work that way. So as we kind of take this a little bit further, we're thinking about the correct data, patient populations represented, because we've even seen this problem with oximetry, right? That certain oximeters aren't going to work with a certain type of people. So we have to think the same way about this. Is the AI biased towards certain groups? And it's easy to get defensive, but we already have something that's biased toward guys like me. AHI. Look at the research behind how we got to AHI. Older, white men shaped like me. Big, thick neck. The rules work great for me, but not for women. Not necessarily people of color, not of different races. So we already have bias built into sleep without AI. And that's a serious problem right now. Because how many women, and we're going to get more into this as I go along, how many women who had all the signs and symptoms of sleep disordered breathing had a sleep study and were said, you don't have it? A lot. Why? Because the hormones are protective and you don't have the DSATs. That's a problem. Right? It's a lot. So this is the process, and it's a really cool picture, is if we look back to the models I was showing you a minute ago, you've got the data, right, that's fed into the system. So if a company is doing, a vendor or manufacturer is designing an AI, it doesn't have to be sleep, it could be anything. They're going to take that data and they're going to put it into the algorithm and begin to program the algorithm and train it or tune it. It's probably the better word. Then they're going to validate it. So that means they take a random sample of the original data and compare it to their system. And then they're going to have to change it and fine-tune it until it's accurate, right? But then there's one last step where then what they do is, go back one. They take that data and they compare it to outside data. So can the algorithm, so if I had sleep labs that I built a program with, some set of data from the original data to make sure I'm accurate, then I'm going to go outside and get data from another set of sleep labs to compare it to my program to see if it works. And that's the typical process of how AI is developed for what we do. And so if you really want to dig into this, I can't even say her name, but she's a physician, I think out of Indiana, that has really been leading the Academy's AI paper, the analysis, the SWOT analysis we're going to talk about next. So as we look at this, what are the strengths? Remember SWOT analysis, if you forgot this from school. Strengths and weaknesses are internal. Opportunities and threats are external. right? That's what a SWOT analysis separates those two out. So what are the strengths? What are the internal strengths of AI? I mean, some of it is really obvious to us. We want that real-world data. We want to have that personalized approach to medicine. We want precision medicine. Love those terms. Can it have longitudinal measures so we're able to measure it over time and compare all these people? I mean, what if you're able to sit down with a patient and say, listen, there are 250,000 or maybe 1 million patients just like you that had X, Y, and Z with their sleep apnea. And guess what? This solution worked for them, and we believe it's going to work for you because you have all the same metrics. That would be pretty amazing. But that's what we're already seeing in other parts of healthcare, and we'll see that at the end. What are the weaknesses? What are those things inside of what we do that could be an issue? I think the biggest one that leaps out of here is bias. Could you train the algorithm to be biased in one direction or another? It's sort of unconscionable. You're like, how could that happen? Well, who would do something like that? Depends on how motivated they are financially. Lack of standards. I mean, that's something the Academy's working hard on to make sure there are standards around that. So there's all kinds of things that could be weaknesses to us that we have to be mindful of. But opportunities are, can we improve access to care? Can we make care better for a patient? Can we triage patients better? I mean, we already kind of see that in the way AI is being used around healthcare, but that's really kind of the dream of it, is how can we get to the problem faster, and then how can we get to the solution even faster? Because right now, think about it. Listen, sir, you need to get on CPAP. We don't want you to have a heart attack and die. We don't want you to have an accident. You're 7 times as likely to have an automobile accident if you don't get this treated. So we scare the heck out of them, right? Who's not done that? I'm going to have to you're not in the club if you've never done that before, right? We've all done it, right? That's what we do. But guess what? Then we wait how many days to get on our CPAP? Or worse, how many days before we have our sleep study? Then how many days before we're on CPAP? So maybe 90 days has passed since we scared the living you-know-what out of the patient. And now we put them on CPAP. We got 90 days, 30, 60, 90 days to make it successful. We're like 6 months at this point of something we said, you need to do this or you're going to die. So here's where it gets really bad. We get to that 90th day and they're not going to succeed. And now we're going to talk about options. I was a part of an oral appliance company for a year, and it was a great experience learning about oral appliance therapy and sleep apnea. But guess what? A lot of patients have failed CPAP by the time oral appliance therapy is mentioned. How many really want to do anything at that point? They either are more motivated or they're done. A lot of them are done. Because, I mean, how many nights of bad sleep did they have? So when we start dialing some of this back and thinking of opportunity, what if we could do this better? What if we could really serve the patient better? I think things begin to change. But there are threats. Over-reliance on it. People take care of people. That's why sleep techs aren't going away. We take care of people. Sleep techs are the most exciting, most fascinating, most driven people in sleep medicine. We're the people that talk about sleep on a plane, at a party. We're sizing up necks. We're thinking about mask fitting. I mean, we're weird. We're some weird people. But we love what we do. Doctors aren't doing that. They don't care. So we have to think about false positives. There's a lot of stuff in here that are threats, but I think we're all working in the direction to help with those. Another great article on how to read and understand machine learning. So this is the better part of the talk, precision medicine. What if we could help? So here's a great picture. This is a friend of mine who has a pneumotac with his mask. It got everything that we would never want to put on a patient to do a sleep study, but this was a research study. But what he's looking at here is that we've got all these different things that we're learning about breathing that can tell us more about the patient than we've ever known before. And that's sort of where AI becomes fun. Because we're able to program the device, the machine learning algorithm, we can begin to see patterns. We can see things in certain parts of the equipment that are giving us information we never saw before. Matter of fact, that's not uncommon. Did you know this is a fun fact. One of the very first auto CPAPs that Respironics made, I think, was called the Virtuoso. Sleep techs were the first ones to figure out, they saw a pattern, a vibration in the airway, and that vibration got their attention. And they actually brought that to Respironics researchers of what they saw, and it was the precursor to the very first Respironics auto CPAP. So seeing unusual patterns is the hallmark of what we do. Matter of fact, there's a friend of mine talking about unusual patterns. She was doing sleep studies back in the late 80s, early 90s, and noticed that these Vietnam veterans who thought they were schizophrenic were going into REM while they were awake. And so they're sitting there in bed, and suddenly they're having rapid eye movements in the middle of the day. And what it was is that their sleep-wake schedule was so messed up from being in battle that they weren't able to regulate anymore. And so they weren't schizophrenic. They just had a really horrible sleep-wake situation going on. So our ability to recognize that has actually been part of our journey as sleep medicine, is seeing these things. But now we're seeing some even more fascinating things, like the collapsibility of the airway. We already see that every day with the respiratory event. But then there's a muscle compensation. And there's the chemoreflex loop gain that we see with Shane Stokes. And then there's the arousal threshold. These four things are very key endotypes that we're learning a lot about, that you guys see every night. But they ended up proven to be pictures of what's going on with the need to learn so much more about them. So we have the pharyngeal collapsibility, the pharyngeal dilator muscle activity, the arousal threshold, and loop gain. So what's the collapsibility part? So we have that increased tendency of the tissues to obstruct. We know what this one is. This was an easy part of what endotypes are, but it's just that collapsibility of the pharynx that we've known about for a long time, right? The velo and hypopharynx that collapses. But then when we get the dilator muscle part of it, this is really fascinating because it's a part of what happens with the body, because what we can see in some patients is that they may actually overcompensate, OSA patients may overcompensate with these muscles during the day and less so at night, and ends up being a problem for them with their breathing. But it's a part of some types of patients. The one that is really fascinating to me is arousal threshold, because imagine this. You're going to put somebody on ASV and they have a low arousal threshold. What does that mean? It means everything wakes them up. So now you're going to put them on a device whose pressure can jump up 15 centimeters of water at a time. I'm just saying, if you're crazy, you have to put somebody at 20 to 5. So we're talking about pressure changes, right? And there can be pretty significant. Well, if you have a low arousal threshold, guess what's going to happen every time that pressure changes? They're going to wake up. So now you have a dilemma. What do I do with this guy? Do I want to put somebody who has, an unstable situation on a hypnotic? I don't know about that. You might put them on acetazolamide, right? You might put them on something that regulates their CO2 rather than on something that could depress their breathing. So see, now we're beginning to see AI tell us some things, so that maybe what we're going to see is some specific things that help direct us in a different direction. But then we get to one that we've talked about for a long time. That's loop gain. What's the most notorious representation of loop gain? Shane Stokes. Loop gain is I love this example. Dr. Malhotra, Atul Malhotra gives this example. He said, the best example of loop gain is a thermostat. Somebody with a broken loop gain, or having a loop gain issue, the temperature changes 1 degree, and the air conditioner comes wide open to compensate for 1 degree, versus turn it on, turn it off just to get the degree down. Well, what happens with somebody who has a high loop gain, which we see in Shane Stokes patients, it's going to mean that the blood gases change a little bit, and what does the body do? Foom, foom, foom. It's going to send those breaths up with that hyperpnea and hypopnea, so it's going to have that big hyperpnea as a part of that, right? So that's a loop gain. So now we take two of these things, arousal index and loop gain, we put them together, or we put the collapsibility of the airway with arousal. So now you got a patient that you're going to try to put a mask on, and you're going to put them on CPAP, and they got a low arousal threshold. Now you might talk about a hypnotic, something that just takes the edge off so they can actually tolerate their CPAP. So now all of a sudden, the thing that we've been kind of afraid of, this AI, has the ability to give us pieces of information that change how we can look at the patient, because all we're looking at right now is a desaturation profile and an AHI. That's all we got. And whatever notes you had that you could glean from observing the patient. But what if we could see more? And so as we think about this, they all matter because they begin to paint a picture. The picture is phenotypes. So that begins to tell us something. We're taking this cluster of, putting them in this bigger bucket to be able to say, well, here's what somebody could look like. Well, that changes everything as well, because now that's where I said a while ago, what if you had 1 million people that look the same? Now they're falling into a bucket of type. And now if I know that type, maybe I go straight to an Inspire. Maybe I go straight to an oral appliance, right? So now we can't do that yet because the payers want us to go down the CPAP road. But what if that changes things? We as technologists, it puts us in a really unique spot. Because if we're able to be the advocate for the patient, or just a sleep professional guiding the patient in their journey, man, that changes everything. Now we're not just a part of the evaluation and testing and therapy. We're navigating the patient's journey. And that, to me, is the fun part of where we're going with this. So there's different articles that point to this, of how these things can lead to oral appliances, therapies, pharmaceuticals, and surgery. So when we get to phenotypes, then we see these, like I said, these clusters. And we can see that there are different ways that people can measure it. But one of the people that has done a lot with it is out of Yale, Dr. Zinachuk, Dr. Yagi, along with Dr. Eckert out of Australia, and Dr. Sands out of Harvard. And so they begin to paint this picture, and you can see some of what we've been talking about, where you've got the anatomical issue with the pharyngeal dilator muscles. You got non-anatomical issues over here, like we're talking about with loop gain, epiglottic pressure. You've got all these things, these 4 endotypes, that begin to paint this picture of where we want to be. So one of them is, it's kind of funny, I stole this from my old slide deck from Respironics. And if you ever saw an auto CPAP explanation, you had these 3 things of P-crit, P-therapy, and P-optimum of what an old Respironics auto CPAP would do whenever it was treating a patient. And so I bring this up to really just show you that the idea of P-crit isn't something new. It was a part of some of this original research around how we were understanding where a device needed to titrate the patient to control the airway. So we've been doing this part for a while. It's just now we're beginning to collect these pieces to the puzzle, so that now we'll be able to say, man, there are these 4 things that we can see from a sleep study. Now, I'm not saying that endotypes are exclusive to sleep studies. You have endotypes from blood work, from lab work. So there's other things that we can see from patients about their sleep from other places. But if we're looking at a PSG or an HSAT, and we can pull that data off of there, that's what we do, right? That's our space. And that's why I love talking about this. So the loop gain, we've seen this before, is this is Denny Eckert's work. You've got somebody that's breathing along, they have a disturbance, and they have a mild response to it. That's going to be a low loop gain, versus the person who has a huge response to it that has a high loop gain that's going to affect the airway and can end up sucking it closed. So you can still have a high loop gain with OSA as well that plays into this. This is a 2018 article to give some reference in time with this work. So Eckert's been doing something interesting with something he's calling the PALM scale. And this just tells you that the researchers aren't just coming up with problems and saying, okay, if we've got these endotypes, what do they respond to? They direct this in certain directions for our patients. And so if we have an impaired anatomy, maybe it is mandibular advancement, maybe it's surgery, position therapy, or weight loss. So it's probably hard to see all of those from back in the back. So I'll read those. So it kind of takes us to this decision chain, right? If we have an impaired anatomy, we could make these physical changes in the patient to make him successful. But if we have a repetitive upper airway obstruction, we may have to look at some other types of surgery, some muscle training like myofunctional therapy, which is fascinating, other medications. We might have to use certain hypnotics like we talked about to kind of calm that patient down so that they can actually tolerate the therapy. And so you can see there's all these different things that end up affecting our choices here. Like at the very bottom, the unstable ventilatory control, the high loop gain. We may have the acetazolamide. Some people even try oxygen. Hard to get that paid for. So there's a lot of opportunities inside of this that where we're now saying, okay, well, if I've got these characteristics happening with the patient, what if we tried these first rather than a distant second when the patient's motivation is gone? That's what I worry about, where I get excited, because this leads to other parts of what Dr. Eckert is talking about here in his PALM scale, is if we have, like in this PALM scale 1, 23% of OSA patients are severe in this category. So this may be a CPAP patient. That's an easy layup. It's when we get beyond the classic picture of a patient, that classic CPAP patient, where things kind of go awry. And we've all seen it. They struggle with their therapy. They struggle with being just adherent. So we break this down to PALM scale 2. 58% of OSA patients have moderate anatomical problems. So inside of that, 35% of patients have no major issue with impairment. So we might use CPAP, we might use mandibular advancement, we might use some sort of upper airway surgery. So it's almost like you begin to see a triage in a sense. If they're classic OSA patient, then we know CPAP's probably going to be the most effective thing. So some of this we kind of already do from our experience, right? This is just taking the ability of technology to bring that for us. So can we have targeted therapy? That's the kind of the third blue box here. So in that situation, 64% of those patients have a less than one non-anatomical impairment, whereas the group before had no major ones. So it could be a combination therapy. I mean, I met a lady she was a neurologist in the Philippines. I was in Phoenix, and she's a sleep doctor, neurologist, all of that, and she had been trying to be successful in CPAP for years, but she's got a short neck, it's a thick neck, and she couldn't succeed on CPAP at all. And then she thought, what if I put an oral appliance with this? So what if this is that sort of thing of what if we knew that ahead of time? To go ahead and have these views of what we could do with that. So this is where this begins to break down further and help us out. And then you got the one at the bottom where it's just a minor issue. Maybe we have an oral appliance, maybe we tell them to keep off their back. It's not a major thing. So it's sort of it's almost like a bell curve in a sense. The two ends of the spectrum, we kind of have those down. Yeah, you've got a little sleep disorder breathing, stay off your back, lose some weight, good luck. Then you have the other end of the spectrum, CPAP for the rest of your life. Let's get at it. It's the ones in the middle that are the complication, because they might need a combined therapy, they might need an alternative therapy, and so that's where it tells us. Well, Dr. Yagi and Zinachuk broke this down a little bit further, and you can't really see this up here, and I apologize for that, but I really want to go to the next slide to really tell the story, is that you've got two patients here with almost a similar AHI. But you can see the guy on the left is severely desatting. The guy on the right is not. But if we're looking at it at face value of what we should do with this patient, we assume from the AHI we should do the same thing. The answer is no. One of them is going to do well with CPAP. One of them is not. Right? And that's just in this study of looking at two patients where almost everything is similar except for that oxygen profile, the oximetry profile. And so that's how we're beginning to be able to segment this out and see this a little bit better. Still got a ways to go. We're not there yet. Typing. So as I think of the value of endotyping, I think of the journey I was on over the last year with oral appliance therapy. You've got somebody that has a low loop gain, a high arousal threshold, but they've got sleep disordered breathing. Then could they be somebody because they've got mild airway collapsibility or moderate collapsibility? They just need stability. I mean, I heard a dentist say for every millimeter you move the mandible forward, it opens up the airway 3 millimeters. That's extraordinary. But if that's the truth, then understanding who might be a great candidate for this is incredible. Because, I can tell you the one thing my 18-year-old son, to be like his dad and wear his CPAP mask at night. That's not on his bucket list. Can't wait to be like dad and wear CPAP. But, what if somebody could wear an oral appliance and it be effective, and we knew we had this data that tells us a little bit more about them that could lead us there. The other one is women. We kind of talked about sore subject with me. I've got a family member right now who I've been talking to for years. Wears me out. I'm like, listen, you need a sleep study. I know somebody. I know like 1,000 somebodies that could do it. And finally has one. Gets a PPG device. My head nearly spun off. And I'm like, all right, let's just see how this plays out. Came back negative. Clinical pathway says she's got insomnia. I was like, yeah, let's see how this goes. And so that came back negative. But that's the stereotype we put on women, is that if you don't have insomnia. So we have a real, I'm just going to be blunt, sexism in sleep. It just is what it is, and we've got to change that. It's something I'm fighting for in the roles that I'm in, but it becomes back to how do we do a better job of helping women. My own sister, I sent her to a lab, and doctor said the same thing. Why is that? Because the hormone system is protective, and women don't deset like men, period. So then why do we have the same rule set? I don't know. It's making me crazy. But here's the tough one. This was a great conversation. I wish I could tell you who this was. The doctor says to me, well, Emerson, that's the clinical pathway. If you fail the home sleep apnea test, you have to have an attended study. I said, well, then why is it that a woman has to pay more for her health care than a man? That's a big question, because that's what's going to happen. Because that copay for that attended study is a lot higher than that copay for that unattended study. Why does a woman have to pay more for her sleep testing than a man does? Because that rule wasn't for the current models of HSAT testing we have. That rule was written for devices with belts, not for PATs and PPGs. All right, I'm going to get off my soapbox. So, great article in Sleep Review if you want to read this about that gap, and I highly recommend it. It was back in July. So as we wrap up soapbox issue, because it's one I'm fighting for, I'll read this and you can read along with me, but the sleep apnea subphenotypes reflective of individuals with different underlying mechanisms who may experience different outcomes and respond differently to treatments. Event duration predicted mortality in both men and women, whereas AHI was only associated with mortality in men, as been reported before. OSA is more likely to be associated with insomnia in women than in men, and it is possible that in women, OSA risk is less associated with the numbers of events during sleep and more associated with the arousal-related responses to respiratory disturbances. Gender differences in OSA phenotypes are well described, with women generally showing greater airflow limitation, increased work of breathing, and sleep fragmentation. Recent studies also show gender-specific genetic variants for OSA. The current results show that mortality risk in women can be predicted from features of their sleep disordered breathing, but the critical measure is likely not AHI. How important is AI? That was my question in the beginning. It changes how we look at things. It's not our enemy. working. I love this next example. So in this example, on top, we have diabetes. On bottom, we have sleep. But the top one with diabetes, again, apologize if you can't read it, but I'll read across the top. So the genotype, a genotype is the part of the genetic makeup of a cell and therefore of an individual, right? So what we're looking at is the person right there. So it's associated with certain type of HLA genotypes. Various genes are implicated. So we move over to endotype with this. The endotype is going to be a decreased insulin production or insulin resistance. So that's kind of like we were talking about before, like with our sleep disordered breathing, we had one of those four things, right? Right? Well, with diabetes, same thing. So instead of airway collapsibility or loop gain, we've got insulin resistance or decreased insulin production. So we move over to the next category of phenotype, where now we have a description, which we're very familiar with, of diabetes. Then we move to the next place of treatment, where we've got exogenous insulin or insulin sensitizing drugs. So that's the pathway across there. We drop down to the bottom here and we're talking about sleep again. We have an unknown sleep disordered breathing, right? That's where we started with this patient. But then we move over, and the first one could be a low arousal threshold with mild airway collapsibility, which moves us over to a phenotype of OSA with disturbed sleep, right? Probably have fragmented sleep. The next place was CPAP, but selective hypnotics may work. See where we're going with this? We're able to build a story for the patient. So the next one is high loop gain, OSA with cardiovascular disease. So this probably is a patient with heart failure, right? So they're going to have that classic CSA, CSR picture we've seen with the patient. In this case, they're saying CPAP, don't agree with that, but oxygen or acetazolamide might be the alternative or adjunctive. So you can see where we're going with this, right? We've got the problem, we've got an endotype, then we've got the patient type, the phenotype, and then we've got a treatment. The last one is moderate loop gain, moderate arousal threshold, so relatively normal. OSA is minimally symptomatic. We do nothing. So this is where this all kind of comes out at the end. And so it leads us to, what if we had a different model? Because the model on one side here is traditional versus a tailored model where we're able to kind of take the patient on a journey. And in that journey, end up on the right therapy for the right patient. And so if I'm a sleep educator, sleep coach, CCSH person, which I really think that's part of our future in sleep, we can own this. We can lead in this. We can be the ones to take the patient on that journey and guide them to therapy. Because here's the thing I don't want you to ever forget. How many people in here love going to the doctor? Thankfully, nobody raised your hand. You messed up my theory. So we don't like going to the doctor. Can you imagine the guts it takes to have a sleep study? It's not a small thing. And we can't forget it's a big thing. I mean, it's freaky. We've all seen the cartoon. It gets passed around the chat groups all the time. The person with all the wires on, and we say sleep. But that's a real picture, right? It's funny, and we've all seen it and done it. But it takes a lot for somebody to get a sleep study. And we can't forget that. And so as we look at this opportunity to tailor healthcare for them, that's where we can take this. That's my vision of what sleep can be. And that's what I'm fighting for with the AST, that we go in that direction. For me, it's a long political journey. But I think it's somewhere we can go. I believe in that. But we've got to work together. We can't be afraid of AI. We can't put up a stop sign and say this can't happen. But if we are not the ones involved in the process, we'll get left behind. But if we are involved and we're looking at sleep navigation, we're looking at sleep coaching, sleep education, and we're changing can we change those numbers on CPAP adherence? Right? I mean, the DME is important. It's different than the doctors. Ours the patient to succeed long term. That's why we got into this, right? So, I love this. I mean, that's really what people are. I feel like that. Here's your sign guy a lot of the time. But, I hope what you heard today is that one is my passion about this. I think that we've got a great future. I do. I know that things like this make it uncertain. But I can remember, like I said earlier, we went from papers to computer. And my gosh, everybody was upset. And then we decided where we could all score on the fly. Oh, we're gonna hurt quality. Oh my God, we're gonna hurt quality. No, everybody adjusted. We were scoring on the fly. Then we went to split night. Oh my God, we're gonna lose the ability to test the patient appropriately. And we didn't lose it to maybe some patients. Then we went to home testing. Well, that's the end of the world. We heard Robert talking about that. It wasn't. It grew our business. Type 2 testing is going to be here before we know it. How do we own that? How do we stay in there? And then when we look at AI, how do we really make it work for us? If you've got AI in your EMR system, how are you making it work to set up a navigation program so that you can really mine, I know that's not a good legal word, but really mine for patients in your system that have sleep disordered breathing, so you can go out there, maybe do a stop bang or something on them, get them in your lab, but use the system to find them. That's what this really comes down to, is how do we make it work for us? Because we're the ones that care. We're the ones that have invested in this thing and have the most to gain and the most to lose. But AI is our friend in this, and as these endotypes become more part of what we do, these pathways begin to crystallize. Now when you're educating a patient, it isn't going to be, we're going to try CPAP first, and good luck, hope it works. Or it's like, listen, we got to do CPAP. We're going to go about 20 days. And if things don't turn around, we're going to get you to the next thing, because we don't want your heart being stressed by surges in sympathetic tone that put stress on your heart, put stress on your blood sugar, put stress on your whole body. We want to solve this problem. We've got an aggressive timeline. See, that's the future I see, is one where we are engaging with the patient at the most fundamental level to drive their success and do it fast. And I think that's an option. And I'm looking forward to it. So thank you for letting me rant and rave and be silly, but I truly believe all this stuff, and it's a fun time to be in the role I'm in. It's scary, and some days I think I've lost my mind, but I'm glad you guys trust me with it. And so, any questions, concerns, accusations, threats, gossip? Yes, sir.
So, I know you are proponent of sleep educators and guiding this model, which it sounds like that. What you really need is to be able to have a sleep educator to guide this pathway down the steps. But it all comes, like with everything, it's all about the money. How do you see a environment where educators are being reimbursed for points where hospital-based labs are going to be willing to pay you to be a sleep educator?
There are places happening like that.
Can you repeat the question, please?
So this is yeah, if you could say it, give a mic over there. Wellstar in Atlanta has a program right now, I think Massey's spoken here before, where they do that. But what they do is not about billing, it's about capturing cost savings. Because what they're able to do is track what they're accomplishing by minimizing readmissions, by getting the patient through the system faster. And so those metrics are really going in the direction hospitals think. Hospitals don't think about profitability. Most of them don't. It's about savings and cost control. And so, yes, there are places where we want that number to be able to bill for it. But the reality is the places that have successful programs like that are capturing their savings. And that's the most successful way to go. Because eventually, yes, could we have that? We want that. We want to have a code where we could do that. We're not there yet. But there are plenty that are capturing their savings and building that in their EMR.
Do you see a difference in acceptance of that between for-profit and non-profit systems?
Oh, there's no question that for-profit systems don't even care about sleep. They care about patient beds. And so could that change over time? I think it's cyclical. I mean, it's just like I've seen hospitals have DMEs and then get rid of DMEs and then bring back DMEs. You know, it's cyclical with those kinds. So for-profit, I've not seen that much with. The not-for-profit that are very cost-oriented have been more in line with it. But then you've got, how can you work with your local physician? How can you build a program for the hospital that goes out and helps them educate and find patients to drive the for-profit business? That's where it could come down to is it goes back to what Jerry said in his talk. People don't act differently than how they're measured. You know, in a hospital system, I mean, I can tell you as a sales rep, I used to sell a program for Respironics that grew business. And I was dealing with a DME that was part of a not-for-profit hospital. And the manager of that DME was measured on two things: budget and patient satisfaction. So when I came in and said, hey, I can grow your business, he said, no, you can blow my budget up. He said, I would love to work. He even said, I would love to work in a place where I could drive revenue. He said, but they don't care. They want me to come in under budget and have happy patients. So it goes back to that, is what matters to your organization so that you capture their measurement. And that is really the key, is what do they care about? Because it's like, I saw a situation that when Todd and I were working at Respironics, there was one of our friends up in Pittsburgh who was working with one of the Allegheny hospitals that had 3 sentinel events. They were on the chopping block. Man, it was all hands on deck, and it was about OSA. And so, man, they implemented a stop bang program. I mean, the president, man, all the way down to the janitor was in on it. I'm being facetious, but everybody was in on it. But that goes back to that. What matters in the organization to either drive safety or drive cost savings or drive revenue? And the opportunity in front of us is like a hydra. There's a lot, it depends on what the problem is that you can solve. That's really what Jerry was talking about in his segment, is identifying those and then solving that problem, because how they're measured, it matters.